All righty. I think we have quite a few people. There are probably still people coming in, but I think we can go ahead and get started because I'm really looking forward to hearing what Dr. Bleyer has to say. So I'd like to introduce Dr. Bleyer. This is an amazing researcher. He is globally recognized as a leader in cancer research and public health, and he's been doing this for some time. Most of his work right now is done at the Institute of in Oregon, and he is the clinical research professor in radiation medicine and the Knight Cancer Institute at Oregon Health and Sciences. But he's also a professor of pediatrics at McGovern Medical School in the University of Texas, and he collaborates with the Institute of Health Metrics and Evaluation at the University of Washington. He has written extensively. He's done a great deal of work, and I have been fortunate to participate with him in some of the research he's been looking at with the correlation with marijuana and opiates. But this work today is he's going to be talking about the increase in both breast cancer and testicular cancer in young adults and the possible connection to cannabis. So with that, I will leave it over to Dr. Archie Bleyer.
Okay, now just as I'm saying hello to you all, thanks for joining us today. I've got my dog who's got to go outside, so I'm going to let Teddy out the door take a moment. And that was recorded.
Yes.
Which means I'll probably have to let him back in. Okay. Increasing breast and testis cancer in young adults, the so-called Cannabis-Cancer Connection, or CCC. I'm going to be focusing, stop share, okay. There we go, on breast rather than testis cancer, in part because testis cancer is now somewhat old hat in terms of the link, the etiologic link between cannabis and that type of cancer, testis cancer. I have no relevant financial relationships or conflicts of interest to disclose. I have just interests, no conflicts. If you hear my dog barking outside, I apologize. In terms of the cancer-cannabis connection history, we were among the first to report the testis connection 11 years ago, and there's the reference in the upper left, when Frank Chen, who discovered this and let us know, the rest of the authors of that publication, while he was a clinical research associate, a data manager at Seattle Children's Hospital, before he got his medical degree at Emory, and now is a assistant professor at the university, at Emory University. So here's the cancer connection of cannabis, or Cancer Connection, CCC, CCC. In February this year, the American Cancer Society reviewed and reported in Lancet the likelihood of cancers, and the most obvious one, which they have supported for years, is testis cancer of the non-seminoma type. We had reported germ cell tumors the most likely cause, so it's apparently the non-seminomatous type. In any event, they also reported a connection with breast, liver, cervix. This is as of the February report. Cancers of the pancreas, thyroid, and also children. And then of the lung, oral, mucosa, larynx, and the head and neck. And most of these are topical in that they're either inhaled by vaping or smoking, or eaten, and therefore as a gummy or other oral ingested substance is exposed more directly to these surfaces. That's all in the reference that's above in the February issue of Lancet Public Health. Now, in terms of methods, this is a difficult area, so I wanted to spend a few minutes on how we went about our work. But before doing so, I discovered this since we published it, the so-called SEER Explorer, which is a new source from the Surveillance Epidemiology and Results Program of the National Cancer Institute. And it was updated as recently as July 2 this month. And it's going to be updated very commonly. It's much easier to use than the previous resources. That includes 2022 data, which I've not been able to include except for some recent analyses. Here's an example of what they provide, and it's instant. As soon as you click what you want to see, it'll show up on the screen, although you have to scroll down to view it. This is the incidence and mortality profiles as an example, but the reason I want to show it to you is that they do exclude 2020 in the analyses of trends, because that year was the first year of COVID. And here's their, sorry, and here's their disclosure at the top with the exclamation mark, that indeed most analyses, and these are done by many researchers now, exclude the incidence rates in 2020 because they were considerably lower. And you can see that gray triangle and gray circle behind it as being lower, because that happened to almost every cancer in the United States at the time. Now, I've used the Joint Point Regression Program for several years. In fact, I had some participation in developing it. This is from the National Cancer Institutes of both the United States and Italy, and allows you to detect trends. When they occur, those are called inflections, usually in time, when they change from one trend to another, or whatever the denominator is in the pattern of one trend to another, whether those trends are linear or nonlinear, and I'll show you an exponential example, and their statistical significance. Not only their p-value, but their 95% confidence intervals are provided by joint point analysis. Now, a very important concept is the average annual percent change, or AAPC, which you'll see multiple times in the charts to follow. That's the average percent per year change with every year in the interval included, not just the change from the first to the last year. So it's average annual percent of each year change. In terms of an example, here are two profiles, the open circles and the green triangles. And in terms of how joint point works, it will then show you where the likelihood regressions lead to for each phase or trend interval. Now you see in this case, for both the green and black curves, 4 trends. That's how sensitive this system can be. And it showed that the trend changed at those 3 time points, 2013, 16, and 2019. So identify generally when something changed. It may not be as accurate. They provide you, though, with the accuracy in terms of how many years, plus or minus, those are likely median or mean values. They also provide that. I'm not showing that. And then for each trend, they give the average annual percent change, the AAPCs, and their statistical significance. And you can see here that most of these happen to be significant with a p-value less than 0.05. They also allow you to compare curves directly. So this compares the green with the black and shows that there's a p-value of 0.0004 difference when they compare each of those values for all the inner years shown. So it's very significant in terms of not just finding trends, but comparing overall trends with each other. I will, in my slides, as I did in the publications recently, show that when the p-values are very low, in this case less than 10 to the minus 8, that's 0.0000001, less than that, I'll illustrate there's the 2 less than signs, the p less than 0.001. That's to indicate how much more statistically significant something may be compared to another trend. This was presented at the last IASIC meeting by Dr. Fink, and it shows how he described the change in the legalization of our states from the upper left between 1991 and 1992, when there was no legalization of any of our states, to the next, and I'll put an arrow on it, the next phase that showed some states legalizing for medicinal purposes, medical use, and then even more states in 2012 to 2013, and then the most recent which he showed was not only the medicinal legalization, but in green here, the recreational or adult use as of April 4th last year. And you can see the non-medicinal states that have been non-recreational states, that is, in blue, that have medicinally legalized marijuana, but not yet recreational. So I took that data even before I presented it and show this step curve, which on the right shows the number of jurisdictions, not just of the states, but also District of Columbia, and here it is right in the middle. And the year they legalized for medicinal use, tetrahydrocannabinol, and of course the cannabinoids that go with cannabis. There were 29 states as of January 1st, 2021. We did stop at that point because we wanted to give the states time to have an effect in this case, breast or testis incidence, rather than picking 2024 when they would include states or other jurisdictions that not yet implemented legalization, and therefore not had that effect on an incidence or other parameter. Okay, so in green are shown the states and DC that legalized medicinal use. We also have the recreational use shown here in the upper right. And there were, oops, I'm trying to get rid of something in the way. There it is. Let's do that again. 13 states that as of just January 2021 had recreationally legalized cannabinol, or I should say cannabis, including the District of Columbia. So now this is going to be a pattern you'll see repeatedly in terms of understanding changes over time, epidemiologically and temporally. And although I'm noting here the recreational legalization, in general, we have not found much of a relationship yet. Either the time interval is too short since the implementation of recreational to affect cancer incidence and other parameters. But as you'll see, with the one exception, there's not much for us to have yet been able to determine. So most of this will be of the medicinal use. Now here's a really striking graph. This shows the age at diagnosis from 0 birth to 45 by 5-year intervals for the increasing incidence. This is the average annual percent change from 2000 to 2019. Not including 2020 because of what I mentioned earlier, but it shows this increasing incidence of testis cancer between age 10 and 40, especially between the ages of 15 and 35. These are statistically significant differences, always because the 95% confidence interval does not include 0. So this is a p-value less than 0.0001, et cetera, because of the separation of the 95% interval from 0. Here is the breast carcinoma equivalence from birth to 55. And it shows even greater. See, this is up to 2.0, whereas testis was 1.5 on the left. The incidence increase, especially between the ages of 20. Better let my dog in. Between the ages of 20 and 34. And therefore, we use that interval, 20 to 34, of which all 3 of these statistical significance are obvious, much less than 0.001. There you go, up there, 2 less than signs. And an average annual percent change of 1.2 for that age range from 20 to 34 for breast carcinoma incidence increase from 2000 to 2019. We did use in our report a wider age range for testis cancer because of the statistical significant differences, even including the 15 to 20-year-olds and the 30 to 35 to 40-year-olds. So that's what we used to evaluate the changes with respect to other parameters like cannabis legalization. I want to mention there's something else going on here, and just to show you some accuracy of these data, because screening for breast cancer starts at the age of 40 in the United States, we'd expect an increase, and indeed, that's what we found, so the data seems to be pretty accurate. But that also could be a different kind of breast cancer, as you'll see in some of our subsequent findings. Okay, so let's take the breast cancer increase in ages 20 to 34 that you saw on the previous slide on the right, and compare it to from 1975 on an annual basis to 2019, actually 2021, but excluding using an average annual percent joint plan analysis, the year 2020. And what you have here, going back to 1975 with the SEER 8 regions, that's all was available back then. The apparent lack of increase in breast cancer incidence from 1975 to 1996, and then a statistically significant 0.001, much less than, compared to no change, even a little bit negative, but not statistically significant trend before 1995. There was a 30% increase from 1996 to 2001. And the question was, what in the United States began after the increase? I should say, what caused the increase after 1996? What in the United States began the increase after 1996? Well, the suggestion is, based on these comparisons and associations, something to do with legalization, because it wasn't until legalization began that the statistical significance of increase began according to joint plan analysis. Now let's look at a little more narrow picture. This is the highest increase from age 25 to 30 or 25 to 29. So I'll put that in yellow at the top. But there, the pattern is even more apparent. Of course, there was a greater average annual percent increase too. And now you see the joint point regression identifying no statistical significance, even a little bit negative, but not significantly statistically, until 2005, and then a striking increase, even exponential. So this is now exponential increase from 2005 to 2021, and an overall 70% increase. So again, the question is, what in the United States began that increase in the 20 to 29-year-olds with breast carcinoma in females after 2005? And if we superimpose the legalization, that's again a suggestion, especially with some recreational legalization occurring here, and maybe affecting that age range even more. And by the way, the 8 SEER regions on which the more prolonged interval from 1975 to 2001 are shown are mentioned here in California, Washington, New Mexico, Connecticut, Washington for recreational, California for recreational, and Hawaii again here for the additional medicinal states. So we just looked at those 8 states, you can see a association. All right, now here's what we published. This was in June. Actually, it was June 6th. It hasn't been, other than e-published, available through the journal as yet, and called Epidemiology. And here are the authors, with Becky Johnson having presented this as the first author at the annual Global Conference on Adolescent Young Adult Oncology in Melbourne last year. She went to Melbourne to present the data because Melbourne and Australia in particular has done a lot of work on cannabis and cancer, the Cancer-Cannabis Connection. They published half a dozen articles, and maybe I'll show you those later. So she was there in Melbourne and presented this to the Global Adolescent Young Adult Cancer Congress. And then there's, I should mention, IASIC Speckpart, Frank, who's now the assistant professor, and me. here's what we did with that additional analysis. First of all, we went back and looked at the increasing number of states and DC, the jurisdictions in the United States that legalized cannabis. And this is all the medicinal states. There is a suggestion with the recreational legalization that the increase of legalization increased more rapidly because of that. And then if you compared the rate here with the previous rate extended or projected, yes, recreational seemed to accelerate the availability of cannabis in the United States in terms of jurisdictions around the country. Now, if we looked at testis cancer, here beginning with 9.0 or 9 new cases of testis cancer per 100,000, so it's a truncated curve, you can see that there was a correlation just visible between this rapid increase and the cannabis legalization increase in the United States. And the testicular cancer increase rate was 1.6 and much less than 0.001 statistical significance. And if we compare those two, the number of new cases, the incidence, versus the number of new jurisdictions legalizing cannabis, you get a correlation like this with a Pearson correlation coefficient of 0.92, 0.92. That's strongly significant. Anything over 0.9 is considered highly significant. Now, if we looked at breast, there's even more interesting pattern in that there was an acceleration near about 2010, and indeed, this is joint point regression from a 0.6, not statistically significant with the number of values available, to 1.6, 0.6 to 1.6, and then statistically significant, even with a relatively small number of values available for analysis. So that this pattern of an acceleration seems to have a correlation visibly, and also Pearson coefficient wise with the cannabis legalization trend. And indeed, now it's 0.95. It's hard to find Pearson correlation coefficients that are high like that, highly, strongly associated correlation level. This is striking. And if we now look at the comparison with testis cancer, it's even more obvious. Steeper curve, higher Pearson correlation coefficient. So there's something going on with breast that's even more obvious than with testis. And of course, the suggestion was it has something to do with cannabis legalization and availability. Now we went one step further, and this gets a little more finite and I think accurate. We looked at the actual SEER states, registries, not just the states and DC, but the states that had regions in SEER. And those are shown by the dark green for recreational and light green for medicinal only. And you can see that there were 6 registries in 3 states with the dark green that had recreational legalization. And in the lighter green, 7 state registries in these 4 states, because there were several registries in some states. But you can see that those are the ones we compared, the green registries with the gray, which are SEER registries that have much more finite and reliable accurate data, because of what SEER does in each of the states and are audited every 2 or 3 years. And in fact, some states have lost their registries because they haven't survived the audits and the accuracy expected. So we compared the green versus the gray, 13 state registries in 10 states versus the non-legal 9 registries in 7 states because of the greater accuracy. So now we're looking at the SEER sites, and this is the cannabis non-legalizing states for breast carcinoma incidence correlation. And in the non-legalized states, it went up. There's something, of course, increasing breast cancer in general. But let's remember the 0.7 APC and a high 95% range of 1.1 or 1.03, statistically significant. But if we look at then the other states that legalized it and compared it with the non-legalized states, you see a steeper curve. It may have started out in the regression analysis a little lower, but it's significantly much greater in terms of a 1.3 average annual percent change versus 0.7, and a statistical significant much, much less than 0.001 rather than 0.0004. So we assumed, and we had done this for testis cancer too, so I'm adding those too. But if we go one step further and look at the pairwise comparison, it's 0.001 or less for both breast and testis, and that comma should be a decimal point. So regardless of whether it's one type of cancer or the other, they're both correlated with medicinal legalization of marijuana in those SEER registries and states that did so. And that's the basic ending or final point of our analysis. But we went a step further and we looked at the comparison of the non-legalizing and legalizing jurisdictions with respect to race and ethnicity. And we found three that were statistically significant: non-Hispanic whites, non-Hispanic blacks, and Hispanics. And you'd have to look at this more closely, but if you compare the AAPCs, 2.1 versus 0.2, 0.8 versus 0.4, and here 1.4 versus a negative before it turned positive for Hispanics. And we assume then it's not just one race ethnicity, it's at least these three. We did not see, although there are fewer persons to analyze, especially for the American Indians and Alaska Eskimos, we did not see a correlation with those two. We went one step further and tried to figure out what subtype. And after looking at hormone receptor negative and positive and HER2 receptor negative and positive, the triple negatives for both hormone receptor negative and HER2 negative, the triples had the greatest correlation. In fact, the others, with one exception, did not correlate. The one exception was HER2 negative. So again, an HR negative, but a HER2 positive that had some suggestion. But the one that was clearest was the triple negative. And that's what we've heard from others, the Australians and the others who analyzed subtype. It's the triple negative, or at least HR negative, that seems to be affected by cannabis. Now we took one step further. Alcohol, especially in the last 2-3 months in the journals, in this case JAMA, has been increasingly associated with breast carcinoma. And I'll go one step further. For both low and high, low, moderate, less than 1.5 drink per day on the average. And by the way, that's less than 1 in males, and less than 2 drinks per day in female, have had a association with breast cancer, even the lowest level of alcohol exposure. So now the report was from 2 esteemed authors who I know personally, one at the University of Washington, another at VCU in Virginia. And they have now linked the lowest amount of alcohol ingestion or measurement with breast cancer. But when we look at breast cancer in the SEER registries, the differences are there, significantly greater increase as a function of the amount of alcohol. So this is high, taking more than 1.5 drinks per day, more than 2 for females, and more than 1 for males. But for females here, there's just 1.5 in the United States, using the SEER registries that are in the states with that level of per capita drinks per day in those registries. And you can see that, in fact, the carcinoma of breast rate is higher, but nothing like we saw in terms of the difference for cannabis use. So cannabis seems to be an even more important At least that's the suggestion. Although alcohol is definitively linked to breast cancer, even with the lowest marginal uses that have been tested, and as recently confirmed by the National Academies of Science, Engineering, and Medicine, quoted by the two authors in JAMA recently. The possibility is that even less correlation of alcohol with cannabis increase in breast cancer than maybe cannabis. Is cannabis a stronger carcinogen for breast carcinoma in young females? Well, we'll come back to that if you like any questions, the alcohol. Now let's go a little further and look at our country to the north. Canada legalized cannabis before most of the country in the United States. In fact, they legalized it nationally. Although there are variations from province or state to state, the provinces are all similar. But in terms of Canada, the green data suggest an even greater increase. And again, these are the 20 to 34-year-olds that we analyzed in our data. So there's a suggestion that Canada has even stronger relationship because they've federally legalized it. Here, APC at 3.2 versus 1.7 in the United States during 2014 to 2019 or 2010 to 2018. If we look at testis cancer, it's interesting that in Canada, and there's something to do with race and ethnicity, because of the higher increase of testis cancer in whites, but in Northern Europeans especially, the world's highest rate. So maybe because Canada is more of that race and ethnicity, especially France and Quebec and the Netherlands and Sweden and Norwegian and Nordic countries and Western Canada, you get a greater increase as a function of their legalizing cannabis nationally in the United States. But in either case, the statistical significance is much less than 0.001. And then here's the temporal relationship. I found this very interesting. So if we look at the age range by 5 intervals, up to age 45, that same age range we looked earlier, and we compare the cannabis use disorder in green, it started earlier, in younger Canadians. Cannabis use disorder in 2000 to 2019 had this pattern, whereas the highest cannabis use disorder diagnosed in Canada was in 15 to 19-year-olds. Compared to that early age peak, we can see the testis cancer, we know how fast it went up in Canada, peak at an older age. It took about 5 to 10, maybe 15 years for the cannabis use disorder peak to correlate with the increase, and this is the APCs again, in testis cancer in blue. But that would fit temporarily, that the exposure to cannabis during the teenage years and young adult years resulted in an incidence increase in testis cancer about 10 to 15 years older. The breast cancer is salient pink here, and that also has that similar delay, maybe a little sooner, a little earlier, although not as impressively because the peak's not as high as it is for testis cancer. But does, in fact, cannabis cause breast carcinoma faster than testis cancer? That's Canada because they nationalized it legally, not federally, nationally. The United States has a similar pattern. A cannabis use disorder was diagnosed in 15 to 25-year-olds, less so in 25 to 39-year-olds. But if you look at the breast cancer, it took 10 to 15 years older for it to peak in the United States over the same interval from 2000 to 2019, and also testis cancer. Testis cancer and breast cancer seem to occur with similar delay from the cannabis use disorder diagnosis and presumably cannabis exposure causing that much disorder and pathological, psychological, psychiatric condition. So there's a temporal, in terms of aging effect here, that the exposure during teenage years and early adult years results in the peaks that we saw in the 20 to 34-year-olds for breast cancer and the 20 to 39-year-olds for testis cancer. I think there's a correlation here too, although it was difficult to test this statistically, and we didn't tend to do so. Now, how could this happen? I mean, is there a biological, cellular, molecular explanation? And I'll say, point off, it's not obvious, and that has to be done. But if we look at the breast, which is what you're seeing in the histopathology section of here, obviously the adipocytes, the fat cells, are fat. You can see them. They're mostly cytoplasm. And I've labeled the areas in the breast surrounding, let's go, the epithelium, which is the ductules, the epithelium where carcinoma rises, breast carcinoma. Sarcomas might rise outside the epithelium, but this is the ductules of the glands and the exits into the nipple of the breast. And so the adipocytes surround the epithelium. It's hard to find any epithelium not adjacent to adipocytes. And the larger, the fatter, the more BMI a patient, the body mass index, the more adipocytes that be around those epithelium cells, and they're surrounded even more thoroughly. Now here are the CB1 receptors, cannabidiol B1 receptors. There are CB2 receptors all over the breast too, but the CB1 are more obvious. And that's the one that's now been linked to this linkage of breast cancer with cannabis, the Cannabis-Cancer Connection. And if you look at the epithelium, it's surrounded by those receptors. And the more fatty the breast, the more they're going to be. And if you look at the estrogen receptors, and remember the role of the hormone receptors, they are adjacent to, within diffusion distance of cannabis that binds to the CB1 receptors and surrounds the epithelium. So topologically, pathology-physically, there's a close relationship. And that could mean that the more CB1 receptors there are in the breast, the more likely they're exposed epithelium of the breast to cannabis and its molecular carcinogenic, or, if possible, benefit, which has been reported too, that there's a potential benefit of using cannabis in breast cancer patients after diagnosed to help them have a slower growth or even a reversal of growth. There's been a series of reports on that. Either way, the connection is so close that one has to worry about it causing or reducing the growth. So summary is that both breast epithelial and adipocytes have those receptors, especially CB1. And yes, it's been reported, and I gave two examples below for those who review later, that there may actually be a treatment for breast cancer, and it's been used increasingly in patients diagnosed with breast cancer, in part to reduce their vomiting and nausea from chemotherapy or radiation, but potentially even for treatment. And that's very controversial, but that's being increasingly so. So even more and more patients with breast cancer in the United States are exposed to cannabis, not just for legalization, but for potential treatment, or at least for evaluation of adverse side effects, including stress and the duress of having the cancer. But if obesity increases the number of fat cells, and therefore the number of CB1 receptors, also some CB2, there's going to be more cannabis in the breast. And so those who are more obese or overweight are potentially more likely to develop cancer. And in fact, obesity is strongly linked with breast cancer. The more obese a female is, the more likely they'll have breast cancer. Yeah, so there's an association there. Now, the interesting studies, and there are very few in the laboratory, but in mice who are adolescents, when treated with cannabis, the number of their adipocytes in their breasts and the size of those adipocytes decrease. And so if there are fewer adipocytes, fat cells in breasts, in the adolescent, in this case, mouse, there may be more exposure to cannabis because as the adipocytes decrease, more gets into the breast epithelium than into the epididymis, because the adipocytes would bind preferentially the cannabis the breast is exposed to. And if the exposure is the same, it will potentially lead to greater binding in the epithelial cells. So those have to be tested as hypotheses. Almost done for questions and comments. There's another possibility, and that's because cannabis are notoriously known as endocrine disruptors. They impair the release of hormones from the pituitary and the hypothalamus via the pituitary, and especially luteinizing hormone and gonadotropins. And because the testis and to some extent the breasts are gonadotropic targets, that if the release of those hormones that regulate the breast and the testis are decreased by a result of the endocrine disruption from cannabis, there would be another mechanism that could explain. In fact, when we presented it last year, as Becky is the chair of the AYA, Adolescent and Adult Oncology Committee, for the Southwest Oncology Group, the first response in the audience was, it's the endocrine disruptor effect. Of course, was the statement that the oncologist made for us before any other statement was made. So this mechanism may even be stronger than binding the CB1 in the breast itself, or CB2. So if that has to be worked out. So if it's endocrine disruption, if it decreases luteinizing hormone, which has a strong effect on the testis and on the breast, and also gonadotropin receptors that are infected, then the breast and testis can be affected by cannabis's biological effects, either in terms of causing cancer, or maybe treating it. And so you can read the rest of this. That's another mechanism that may play out as should be tested in the lab. And the last bullet at the bottom is this mechanism of endocrine disruption has been supported by environmental carcinogens that cause breast cancer and are known to be acting by that mechanism, endocrine disruption. There are multiple chemicals in our environment we hear about more and more, although the EPA now has lost its research orders who were dismissed on Friday last week, so we won't probably learn more from the Environmental Protection Agency. Okay, finally, with 15 minutes to go, the Australians, especially this group from Rees and Hulseth et al., have published multiple articles on this. In fact, here's one in the Archives of Public Health. It was published in March 2020, and here's 3 more. And in this case, they report in the first article of 48 pages, and the second article listed here of 22 pages, that including sociodemographic, they factored in these confounders, sociodemographic, socioeconomic, and hormonal risk factors. And they did it for the European data and for the United States using SEER data. And then their 48 and 22 pages have concluded that cannabis is a more important carcinogen than either tobacco or alcohol, which is what we sort of thought we were seeing with female breast cancer in the United States. Now this has to be affirmed or denied, but they are now claiming cannabis is even more important than tobacco. Okay, last thing. How significant is this? Well, if we look at the increase, again, the average annual percent change during 2010, I picked the last decade for this because it's going up more rapidly and maybe more accurate. Using the same age range we used before, if we look at the APC, which you've seen before, but with and without testis among males what you see is that if you include the testis, the increasing incidence of cancer is this great, 3.6 or 7 or even 8, with a very narrow, but 95% confidence interval. And if you exclude the testis, you only get that much of an increase. So most of the increase, actually 94.5% of the increase in the United States of test cancer, I mean of all cancer, that's, I misstated that earlier, of all cancer in males of 20 to 35 years of age is due to testis cancer in the United States. That's how important that increase in testis cancer to explain the increase in incidence of cancer in that age group. It's not colorectal cancer, which is getting so much more publicity lately, it's testis. In females, it's about 40% of the increase of overall cancer in females. It's less, but it's still almost half of the increase, and it's more of a contributor than any other cancer. So the overall increase of cancer in 20 to 34-year-old females is accounted for about 40%, almost half, of their increase in breast cancer. That's how important it is in terms of the overall increase in cancer in the United States in that age group. So the final point about that is young Americans, the increase in testis and breast cancer had a major impact on their overall cancer increase. Okay, final summary. The epidemiological, and that's ecologic and has to be emphasized, has breast and testis cancer in young adults increasing because of the cancer-cannabis connection. And in summary, more, or if it could be reversed, rejected, disproved, more or less clinical and translational laboratory clinical scientific evidence is urgently needed, yet potentially may be more difficult because of imminent decrease in funding and also of researchers, not just at the EPA that happened last week, but at the National Cancer Institute, the NIH, cancer centers across the country, and the funding issues that have occurred. Finally, we need to do this. Get the research to undertake more evidence before more states and countries legalize the adult use. I put that in quotes. That's the recreational quotes adult use because indeed it's never limited to adults. It's always going to affect teenagers and sometimes even more so. So it's really before more states and countries legalize adult use, but actually unintentionally allowing far more use in teenagers. Before the federal government reclassifies cannabis as Schedule 3, Schedule 1. That's in the agenda. Before, cannabis is more recommended, even more recommended for cancer patients, especially those with breast cancer. We need to know about this. And finally, before other cancers are clearly cannabis cancer connected, not just those mentioned. Therefore, the current research landscape needs more effect, not less, more impact, more investment. Because what we know is ragged above the surface of the ocean compared to what's below. And we need more of those rays of light to understand this. And thank you for your attention to this epidemiologic exercise. All right, back to you. I'll undo stop share.
That was
You can look at any comments.
excellent, excellent. Yeah, we have quite a few questions. And I just wondered, to start off with more and more women using cannabis when they're pregnant, it seems to me like it would be good for people to start doing some longitudinal prospective studies on these women.
There are data in the laboratory of cannabis affecting the fetal testis. I don't know if I remember something about the fetal breast, but there's an adverse effect of of the cannabis on the fetus in laboratory animal rodent model, if I remember right. There is, as far as I know, no yet published data of human followed pregnancy, delivery, and their children, and any cancer increase that may have occurred subsequent to birth. I think there's some psychological adversity that's been reported. You might know about that, Libby, but in terms of mothers having children after cannabis exposure, there's been some evidence, but not the cancer connection yet.
Well, yeah, and I just wonder about their cancer connection too. But anyway, the first question, there are actually a couple of questions on this. Would you support a REMS, R-E-M-S, on medical cannabis, testing for breast and testicular cancer prior to dispensing and routinely twice a month medical marijuana?